What I'll ask you to do is, if you'd like to introduce yourselves, and then there'll be the opportunity to make an opening statement of 5 minutes or so, and then we will move to questions. But if you'd like to start by just introducing each of yourselves and your role, and then if you want to go ahead and make your statement.
Thank you, Chair. Good afternoon, everyone. My name is Mairead McAlinden. I'm Chief Executive of the Southern Trust.
John Simpson, Consultant Psychiatrist and Medical Director of the Southern Trust.
Seamus O'Reilly, Consultant in Emergency Medicine and Associate Medical Director for the Southern Trust in Emergency Medicine.
I'm Debbie Burns. I'm the Interim Director of Acute Services, and I look after the hospitals in the Southern Trust.
I'm just going to check before we start. Again, everybody here at the back?
That's a good idea here.
You might need to move your mics in a bit. Indicate to us if you can't hear, and we'll try and make sure that whether it's from ourselves or the panel members, I just want to make sure that everyone can hear. Mairead, if you'd like to make your opening statement.
Thank you, Chair, and thank you for the opportunity to make a short opening statement to set out how the Southern Trust respects, protects and fulfils the human rights responsibilities in relation to the right to health. I just want to be very clear about the role of the Trust. Our role is about delivering good quality care and in a way that supports and enables our population to be as healthy as they can be. Our services are shaped by the needs of our population. They are shaped by our service agreement with our Commissioner, by the needs of our users, government priorities, and by the £500 million a year that we receive to provide these services. Our population in the southern area is fairly unique. We have 360,000 people living in the Southern Trust area. We have the largest ethnic minority population in Northern Ireland. We have the largest population of people under the age of 19, and we have the fastest growing older population. The vast majority of our 13,000 staff also live in the southern area, so we live where we work, and I'm one of those people. So that makes us have a very strong personal as well as a professional commitment to delivering excellent care. In the Southern Trust, we really do strive to adopt a human rights-based approach to the delivery of our care. I'd like to think it's part of the day job. This informs all of our decisions, from the boardroom to the front line of care. How we value our staff, how we work with service users, how we work with other partners, and how we contract for goods and services. Professor Hunt, I heard you saying at an earlier hearing that a good health professional is a good human rights worker. I believe that too. But as leaders in our organisation, we have specific responsibilities. We have to create the right organisational culture. We have to target our scarce resources. We have to listen and respect and involve users. And we have to work with our partners to make sure that we've got a system of quality care where the right to health is protected and respected by all our staff. I'm a very practical person, so I like to make things simple. So what does that mean for the person on the street, the person who comes into our emergency care department, or the staff on the front line of care? For me, it means a focus on providing safe, high-quality care, treating people fairly and with respect, whether they are users or staff, respecting people's individuality and dignity, supporting people to make the right choices, valuing our staff and supporting them to be as good as they can be, and listening and learning when things don't go as well as they could. When we talk to people in our community, and we very frequently talk to elected representatives, service users and community groups, they tell us how important access to emergency care is to them. Last year we had 250,000 patient contacts across our 2 emergency departments in Craigavon and Daisy-Hill, our minor injury units in Armagh and Dungannon, and our GP out of hours service. Have we always got it right for all of those people? No, we haven't. We strive to do it, but we don't always get it right. And I personally apologise to anyone who's had a poor experience of care or whose outcomes haven't been as good as they could have been. But as a Chief Executive, I have to say that there is a real commitment to doing our very best for the population we serve. That's at every level of the organisation. Emergency departments are one of the most complex services that we deliver. We run the service 24/7, and it is open access to everyone, irrespective of their age, their culture, their disability, or their social status. What that means is that we have to be ready to safely care for anyone that comes through our doors, and we have to be prepared to adjust our care depending on that person's specific needs. During this session, through the questioning, you will hear examples from my colleagues as to what we've put in place to make those adjustments. It ranges from access to interpretation and translation services, to our multicultural beliefs handbook, which we share, which guides our staff in terms of cultural sensitivity. But for me as a Chief Executive, the quality of care in our emergency departments is a barometer for the quality of care in our whole system. It's an indicator of how well our hospital is working, and it's an indicator of how well we're working jointly with community and primary care. And all of that joined up working is critical to delivering the very best standards of care. We have a whole range of indicators by which we judge how well our emergency departments are working. I know there's been a lot of debate through the hearings about the value of a 4-hour target. It's only one measure, but I believe it's a very important measure. It's important to make sure that people are treated quickly, to avoid overcrowding in the department, and overcrowding does affect and can affect the quality of our care, which is not good for patients, and it puts pressure on staff. Commissioner Reynolds, hopefully when you did your site visit to Craigavon, you saw the whole range of other measures that we use. Triage within 15 minutes, a 60-minute plan for diagnosis and treatment to start, our electronic care record, benchmarking ourselves against best practice standards, looking at the competency of our workforce, reviewing the outcomes of our care, and listening to the voice of our patients in a whole variety of ways, such as our ED user group, our staff as service user system, obviously the patient and client experience standards, but how we use complaints and incidents and the feedback from the 10,000 voices to learn how to do things better. We want to keep improving. We are absolutely committed to that. We listen to feedback from our users and from our staff, and we've looked to experts to come in and tell us how to do it better. We have particularly learned over a very difficult winter period earlier this year, and hopefully you'll hear some examples of what's been put in place. I'd like to conclude by recognising the dedication and support of our staff, not only in our emergency services, but right across our services. I know that Seamus will particularly say that our emergency departments are not islands. They very much depend to be part of our hospital system, drawing in expertise from elsewhere. And also our hospital system depends on our community and primary care services and our partners in the voluntary and community sector. We are very fortunate in the Southern Trust to have highly committed staff who care deeply about the job they do and the people they serve, and who really understand that we must work together if we're going to provide the best quality of care. I'd also like to take this opportunity to say how fortunate we are to have the support of our local population. We have people who give up their time to provide us with a user perspective, who volunteer with us and work alongside our staff, people who take the time to thank staff when things go well, but also particularly to those who've had the determination to tell us about a negative experience because they want us to do better for the next person. We're here to listen to those experiences today. I know you have some users who are coming along, and we will be here to listen to them if they want to talk to us afterwards. I know you have many questions for us in a short amount of time, Chair, so if you don't mind, I'll leave it there.
Yeah.
Thank you.
No, that's fine. Thank you. Mairead, I'm going to start and then I'll pass you to my colleague Marion and then finally to Paul. And I'm quite happy for questions to be fielded by you and colleagues, so they're addressed to the witnesses as a whole. If I can start really with a very broad one, which is, can you really tell us what are the key resource and non-resource issues that face the Trust in delivering the quality of care that you said right at the outset is your primary purpose? And tell us how you're tackling those resource and non-resource issues in practice.
Thank you, Chair. I'll start, and no doubt my colleagues will join in. But
sure.
For me, there are three very key issues right at this point in time. We are facing into winter yet again, and about this time last year, we received some additional money to open some extra beds across our system, and I really do believe that helped us to cope during a very pressurised winter period. I'm very aware with the political debate on the large scale that finance decisions are being delayed, but for a hospital system we really need to be making some of those changes quickly.
Okay.
For me, a second issue is around our workforce. We have a budget of 7 million to run our 2 emergency departments. Thank you. We actually spend £10 million each year. And that gap of 3 million is around making sure that we have sufficient staff on the ground to safely provide a service across the 24-hour period. Some of that expenditure is because of a shortage of certain key workforce, such as some of our consultant staff, some of our middle grade staff, and some of our emergency nurse practitioners. And I know that in speaking to the Chief Nursing Officer earlier, there is a real commitment to train more specialist nurses to work in our ED department. But that means as an organisation I have to choose and prioritise our emergency department in terms of that £3 million gap and make sure that is found from elsewhere. I suppose the third thing for me is around our physical accommodation. We have recently invested almost £2 million to improve the emergency department in Daisy Hill, and it has vastly improved our ability to provide dignified services within that environment. As Seamus will tell you, the emergency department in Craigavon could do with similar investment. We're currently developing a business case to make that improvement, and I know the Minister has a commitment to try and find that capital money for us, but we know there's many demands on that as well. So I hope that answers your question, Chair, but I'll maybe ask my colleagues, do they want to make any further comment?
I think it answers my resource question, but perhaps your colleagues might address the non-resource issues that you face and how you're dealing with those.
Maybe I could take that question if that's okay. I think Mairead has summarised very well the resource issues, and we do have to acknowledge the support that we've recently received from our commissioning colleagues in terms of additional manpower. I think from my perspective and Seamus's perspective, as Mairead said, the ED is a front door, it's a barometer, but the hospital system has to work as one. To allow a person to be admitted into the hospital, another person has to be discharged from the hospital, and that not only requires Seamus's input, it requires his medical and surgical colleagues in the hospital, and it requires my community colleagues to assist me. So what we have been working very hard on in the Southern Trust for several years, and this year are re-energised to do before we come into the winter, is to try and develop the culture where we have a whole system approach to addressing the ability to prevent things like crowding in the emergency department, because crowding in the emergency department to me is somewhat of a failure of my whole hospital system to meet the challenges that Seamus and his staff are facing. So we are trying to look constantly at improvements that we can make. So in the emergency department, Seamus and I and Barry Conway, who's here today, the assistant director, have worked a 60-minute plan with our clinical colleagues to try and pull the triage of emergency patients forward, to provide them with pain relief earlier, to then pull their first interaction with the doctor forward, and to make a decision either to admit or to discharge with treatment. But Seamus then needs the help of his medical and surgical colleagues if it is to admit, to make that decision and to allow that person to be admitted to a bed. So we're also working with our medical and surgical colleagues in how they work, and they have changed just in the last 3 months the patterns in which they work to better support the emergency department. So what we're trying to do is engender a partnership approach that the whole system can assist to allow patients to be safely and timely admitted to our hospital beds and treated, and then be safely discharged home. And I'd have to pay tribute to all my colleagues, both in the hospital and in the community, and we're working together to do that. So I think it's that, it's engendering that culture of it's everybody's issue, that the emergency department doesn't feel that it's standing by itself, and that all our staff in the hospital are aware of how much pressure the emergency department is under at any one point in any day. So we would meet 3 times a day as a hospital system to look at both our sites and how much pressure they're under, and the actions that all colleagues, not just the emergency department, need to take to prevent issues of overcrowding. So I think it's that culture of it's everybody's problem, and not just the emergency department, and the hospital is streamlined to assist them to do that.
Can I ask just a supplementary on that? And you've given some practical examples there of how that works in practice and how you have meetings during the day. How do you ensure the kind of joined upness between the emergency department and, for example, social care, which you mentioned there, which may not be a 24/7 service? What's the practical whole system approach you've taken to trying to knit that together?
No, you go ahead.
Organisationally, and for many years, we have had what we've called a timely discharge group, and it means that Debbie, as the director of the hospital service, jointly chairs with the director of older people in primary care a group that monitors and seeks to improve the timeliness of our discharge and to eliminate any delays. We've recently had an independent expert come into our organisation, thankfully paid for by somebody else, to look at our patient flow. And they have commented that our discharge processes are one of the most effective they've seen in the UK. And I attribute that to the fact that I have got 2 directors who are equally committed to making sure the flow in our hospital is good. Debbie, do you want to add to that?
I think we need to give you the high level view on a practical, very, very daily practical basis. When a person, for example, over 65, and this is a recent innovation in the last 12 months, when a person over 65 is admitted by Seamus or his colleagues into either hospital, immediately there is a trigger back to the community teams to say, this patient is being admitted. Do they have a key worker? Do they require social care input when they're at home in their normal circumstance? That information is transferred back into the hospital to the ward in which that patient is admitted within 24 hours. That immediately starts our ability, the ward staff, the hospital social work team, that immediately starts their ability to plan for that patient's discharge. And also to let the hospital staff know how that over 65 person was at home before they had this acute episode, and for us to understand what supports they had and what they're going to require when they're able to be discharged. So quite a lot of that joined up working is down to very careful and immediate triggering of planning. And so yes, it is difficult to enact a new, for example, social support package over the weekend. But if we know about that on Wednesday, we can do something about that before Friday. So on a very practical basis, we have what we call an information hub for all our over 65 admissions, where the information transfers from the community through to the acute system and back from the acute system back to the community teams. That's one example.
And not to delay, but recently I went round a number of the wards, and one of the questions I asked is, do you make use of that community information system? And what the staff in the wards actually said is that, yes, it's useful for planning discharge, but because the community worker is more familiar with the patient, they gain information about who their carers are, what support systems they have at home, what some of their particular needs are, and all of that helps us to treat people with quality while they're in our care. It's not perfect. We are trying to promote the use of it. It needs embedded further. But we started this in the summer because of feedback both from users and from our staff, which said, when someone comes into our service, we don't know them, and we need information from the people who do.
Can I give a practical example of a patient, and we pick elderly because they're a very vulnerable part of our community, who comes in who does not have an acute medical need dictating admission to an acute medical bed, but maybe has gone off their feet or has had several falls, and the feeling is that they're not safe to go home without some further assessment of their needs and without putting mechanisms in place to support them when they are discharged. During the week, we can link in very readily to a social worker, to an occupational therapist, to a physiotherapist, and to a senior doctor in geriatric medicine, and they will link in and come and assess that patient and assess all their needs. And on a lot of occasions, we're able to discharge those patients very safely home, knowing that a care package has been agreed on for those patients. And those staff are dedicated to our department.
Okay, can I move us on, and then I'll pass to Mairead. One of the issues I think we're interested in, and one of the things we'll hear about today in closed session, is an experience of someone around dignity in dying. And I'm interested that the Trust has implemented something new in terms of looking at your mortality and morbidity processes and through meetings with specifically within the emergency department. I wonder if you could tell us a bit about the background to why you felt the need to do that and what difference that approach is making. I know it's very early days, but
Sure, if you don't mind, I'll maybe ask John to start, and then Seamus can give the frontline perspective.
yeah, sure.
In terms of how we overview,
It's really what were the issues that led you to make the change to
Yes.
bringing it back into emergency department only kind of meetings, and what difference that's making. And so what are the issues, how are you tackling them, and what progress are you making?
Well, the issues are more general to start with, in that morbidity and mortality meetings are in existence for a number of years. I mean, I went to my first one in 1981 as a junior doctor, so they're part of medical culture, a very healthy culture, in terms of looking at deaths, expected and unexpected, and looking at complications of treatment in whatever specialty. But they have grown up very differently in different specialties, and there's no overall view as to how they should work. So that's one issue of them. The good thing is the culture's there. So about 2 years ago, we decided to try and modernise. The drivers for modernisation are that there are more subspecialties which don't necessarily fit into the big M&M meetings, such as medicine, surgery, obstetrics and gynaecology. So emergency department would fit that. Bill, as would radiology, dermatology and other smaller specialties. If Seamus doesn't mind me calling it a small specialty, it's nearly a specialty.
It's a lot of people.
The other problems about it is it's largely medically led and focused. It's also largely focused on education rather than actions and outcomes, and it's not necessarily very patient focused. So we started with the view to reforming and modernising M&M. So it was out of that process then that we went to all the specialties, all the specialty leaders, to ask them what they wanted to do about it. ED traditionally would have not fitted very well either into medicine or surgery, so they thought it best to have their own separate meeting. The rejoinder from me would be that it had to feed into it. So the structure that we're still creating now, it's maybe another 1 or 2 years to go, is that subspecialties will feed into the larger meetings as required, which would be really in two scenarios. One, that locally they aren't able to fix what needs to be fixed with their local managers, and it needs to be escalated. Or secondly, that the lessons that they're learning from ED have a wider implication across all specialties. So that's the model that we're developing. Another tier to that then, which is again only a year in existence, is an overview from my point of view. A monitoring committee which we've started, which sits between the Chief Executive, Senior Management Team and Trust Board and the M&M meetings. So that committee consists largely of the chairs of the various M&M meetings and a non-executive director from the Trust to bring the, if you like, by proxy anyway, a patient view and oversight into how the system develops, and a senior nursing officer in terms of education and the multidisciplinary aspects, as well as pharmacy and other inputs. It's a work in progress. The constituents of that committee may change over time. The general idea is, though, that from my point of view as a medical director, one of my main jobs, I think, is to ask questions of the system that the man in the street would ask. Why did you do that? Why did you investigate that death this way and not that way? Except I'm asking those questions with the benefit of medical knowledge. The advantage for the doctors is that, particularly with respect to revalidation, that's the need for doctors to prove their competency every 5 years, is that it provides a framework for them to gather up the evidence that they need, that they're reviewing their care, that they're listening to their patients, and that they're taking actions. So their experience of the M&M process forms a large part of their portfolio to be revalidated. So that's the background for ED. I mean, Seamus can talk more about the specifics. There have been 3 M&M meetings in ED so far. The interesting thing about that meeting and a few others that go on, such as the stroke physicians, mental health, is that the smaller groups, if you like, starting from scratch without the history of the old M&Ms, tend to be multidisciplinary straight away and much more closely focused on the patient. We can't say that we have patient involvement. The steps that we've taken to get to that point, as I've said, the M&M Monitoring Committee has a layperson, non-executive director, to help us focus. Seamus will tell you about his patient group to inform ED locally. And what we have in draft, but not in practice yet, is that I will be insisting that each death and other complications presented to any M&M throughout the Trust has a patient experience focus on it. So there will be a question that they will have to fill in. What was the patient's, along the lines of, what was the patient experience of this complication or the family experience of this death? So those are the directions we're going in. It's not really rocket science. It's been done elsewhere. There'd be a number of trusts across the water and in the States who would take this approach. The outworking of it will be in a year's time that it's not so much a medical morbidity mortality meeting anymore. It's a patient safety, quality improvement type system, and that's what we're striving for. I would say we're about halfway there.
I suppose very quickly we got to where we got for very practical reasons as well. One of it was that our staff were having to choose between different morbidity and mortality meetings, which one they go to, surgical, would they go to the medical one, would they go to the paediatric one, and we felt that, I suppose from a purely a practical point of view, that was impossible for them to do. So that's why we decided that we'd have our own individualised morbidity and mortality meeting, which we started off as being multidisciplinary, so our nursing staff are involved in it as well. And I suppose the take-home message from it is that if you involve more of the multidisciplinary team, you get more of an output from the morbidity and mortality meeting. And some of the things that we have achieved, if we take pain relief, was one of the things that was brought up as a quality indicator as part of our morbidity and mortality. And we implemented changes to the process of how pain relief is given to patients when they present in pain to the department. We've also reviewed some some deaths that we felt should have been referred for serious adverse incidents and hadn't at the time. But in review with this group, we decided that we would refer those for serious adverse incidents and for further investigation. CMO letters. We've looked at those in particular in relation to warfarin and head injury, and on the basis of that we implemented the changes that we felt were required to fulfil the obligations of the CMO letter. So there's real tangible outputs from the morbidity and mortality because we now have ownership of it. We're inputting into it, and as I say, it will develop. And it'll develop that we may have more multidisciplinary involvement from social workers, physios, everybody as time goes on. And ultimately it may well be that we do have a patient representative sitting on that group and actually providing a patient perspective.
Chair, would you mind if I maybe just said a very few words to set that in context? I became acting chief executive in 2009, just about the time that Mid-Staffordshire started to emerge. And naturally, we were all asking ourselves, could that happen here? And because of that, we completely reviewed our whole governance structures to make sure that they were more open and transparent, that staff understood and could use them, and that actually we were taking information from everywhere in our system to help us make good decisions. When John came to me and said he wanted to review the M&M system, I very much welcomed that, because there was a danger of that being a dark room discussion where doctors talked to themselves about things that had gone wrong and the medical profession sorted it out among themselves. Now, I don't have a clinical background, so you'll forgive me for using some of the terminology. So this openness of, making it more multidisciplinary, making sure that the decisions in that group came into our governance system was critically important. And you asked about the drivers. I think it's that we learn from everything that's happening in our system.
Mm-hmm. Okay, thank you. I'm going to pass you to Marion.
Before I ask my two questions, I'm just wondering, Debbie, if you would clarify something for me. You said that medical and surgical personnel had changed their working pattern to support the emergency department, and I'm just wondering what changes have been made?
Surgery had, I suppose, already changed in terms of they were working a surgeon of the week model, where one surgeon in that team was freed up to manage the emergency patients that Seamus admits, and to review the patients that are already in the ward, A, to see how they are, and to have a senior consultant review them every day, B, to help them, if they're ready for discharge, be discharged in a timely way so the next admission can come up, and also to receive and take to theatre if necessary the emergency patients that come up from the ED. The physicians had a slightly different model, and we believed that perhaps we could do better, and they felt they could do better by the patients, by having each patient have a consultant review in the wards every day. That way we could enact your treatment plan quicker, keep better tabs on that, and also then make decisions about discharge as well. So they have changed their job plans, they have amalgamated themselves into teams, and there's a team of between 4 and 5 consultants, and they take charge of a ward each, and every week one of those consultants is physician of the week on that ward. They therefore do a round. They start their round at 8:30 in the morning, and they will go back and do another round in that ward at 4:30 in the afternoon. That provides great continuity of care for patients. The junior teams of doctors are also based in the ward, so there's always doctors centred on that ward to take action when required. Families are already feeding back, and the consultants themselves say they have great now communication with families in terms of taking decisions, and therefore that improves the flow of patients in the wards. Senior decision maker every day, twice a day. And they're also available now that we can, because they're in that pattern of working, we can not only admit patients medically to our medical admissions unit, we can also admit patients with longer term conditions that are known to certain clinicians to a ward that they are familiar with, and that the team of consultants already know them, and that's a huge improvement as well, we feel, in quality. So not only is it improving the flow, and we can already see the impact of it, it is also improving the quality and continuity for patients as well. So that's just been enacted, so we feel that's a major step forward.
Thank you very much for clarifying that. I'm going to put my questions out of sequence because it really follows on from what you said. The Southern Trust seems to have made considerable effort to have a cultural change so that emergency care is integral to the whole community care and hospital system. And you also have put an awful lot of effort into improving inflow and outflow processes so that emergency care isn't the sort of meat in the sandwich which is always under pressure. Do you feel that that contributes to the Trust having better statistics in terms of the 12 and the 4 hour waiting times? And would that model work in bigger hospitals, say regional facilities such as the Royal, where they have they're working across the whole province? I'm just wondering, do you think it's a model which could be generalised?
In answer to your question, Commissioner Rellens, I have to say that all of those improvements were specifically targeted at making our emergency department as effective and as efficient as we could possibly make it. I think one of the advantages that we have in the Southern Trust is that our clinicians generally have very good relationships. Our managers and our clinicians have extremely close working, and our general practice, our GPs, we have one of our associate medical directors is a GP, and that's his job, to help us engage with general practice right across the southern area. So relationships are critically important. A system will only work as well as the people who work within the system. I'm going to let Seamus comment on the applicability, because a number of people have visited our units to see, and it's not just in Craigavon, in Daisy Hill absolutely the same thing, and in fact because Daisy Hill's a slightly smaller hospital, those relationships are even closer. So I'm going to maybe ask Seamus if he wouldn't mind commenting on that. Sorry, Seamus.
Thanks. I think the thing about emergency care, and I mean, I've been in emergency care for well over 20 years now, and I've seen vast changes in how that's provided, the expectation from it, and quite rightly the expectation from the public that they'll get a quality service. And over those years, I've had to change on a regular basis how we work, how we do things, and I've had to learn to work closer with managers and commissioners to achieve all those. We're continually changing what we do, because the service changes. It used to be that our peak of activity would have been early in the day, 6 o'clock for instance. It's now occurring at 9 o'clock at night, so we have to be aware that we need to adjust how we work and the services we provide and how things work to keep up with the change that there is there. Will this apply to, and what we do, apply to bigger hospitals? Will it apply to smaller hospitals? I think that's a very difficult question, because they're all different beasts. They all are made up of different personalities. They're made up of different systems. They're made up of different managers. Even the very size of the units dictates what you can and can't do. I don't like to say that we've got it sussed and that we've got it completely sorted, and that would be wrong for me to say that, because we haven't. It's a job. It's a working job. We need to be working continuously at it. I think there's certain aspects of what we do that we do well. I think there's certain aspects of what we do that we could improve and learn from other people. But I do think that some of the stuff we do, and one of the key things, and I think, I'm not saying this just because the managers are here, is that we do work very closely with our managers. We drive the change. Regardless of what Debbie thinks, regardless of what Mairead thinks, we as clinicians are driving the change. The clinicians, in relation to the emergency department, decided how the new rota would work, how we would provide 24-hour cover with senior doctors. We then approached management, who worked with the commissioners and ourselves to achieve that. So little system changes we make with our managers, and we expect them to support us in relation to that, and they have supported us. And I think that's quite unique in that we do have that working relationship. Staff would know Mairead, they would know Debbie, they would know Barry, because they're in the shop floor, if not every day, sometimes every week, even being in at weekends, and there is that visible presence, and that's on both sides. It's not just a Craigavon side, it's on both sides, and that's how you get the job done, I think, by working closer together and by looking at your systems. And if you don't have ownership of the system, so if clinicians and nurses and allied health professions don't have ownership of the system, it will not work. They need to develop that system, own it, and drive it forward with the help of their managers.
Thank you very much. Thank you. My final question is about responsiveness, Janita. How does your trust ensure that you've got a very large ethnic population, some who don't have English? How do you deal with them and their needs? How do you deal with children, because you don't have a separate children's emergency department? How do you deal with those who are mentally ill and coming at acute phases of illness. So what processes has the Trust in place to ensure their needs are identified and met? And is there anything that you have identified that you would want to do differently?
Thank you, Commissioner Rounds. You've mentioned 3 very specific groups. If I could start with children. In both of our hospitals we have what's called a paediatric ambulatory unit. In Craigavon it's open from 9 o'clock in the morning to 10 o'clock at night, and in Daisy Hill from 9 in the morning to 9 at night. That's Monday to Friday. And that means that when a child comes into the emergency department and they're triaged quickly, a decision is made that whether they need the resuscitation or other life-saving treatment that Seamus can provide, or actually whether they could go up into that ambulatory unit and receive that service from a professional in paediatrics. So that has enormously helped the flow and the care that we give to younger children. In terms of our ethnic minorities, as with every service, we have tried to provide our staff with tools and support, whether it be access to interpreting, and we are the largest user of interpreting service in Northern Ireland by far, and that relates to our population. Or whether it's about our staff understanding some of the cultural sensitivities. And that is balanced with our emergency department being very busy. We want people to stay there for as short a time as possible to get to the right place. And I think that's particularly relevant with our patients who come in with mental health issues. We have mental health liaison services which come into our ED department and support our staff. We have a card before you leave scheme. But again, it is in the context of making sure that we understand the needs of that individual and to get them to the right place where those needs can be met as quickly as possible. I'm maybe going to ask Seamus and Debbie to give a couple of examples. Maybe that'll just put a wee bit of flesh on those bones.
Thank you very much.
I think it would be fair to say, and we used to have a separate paediatric facility in Craigavon Area Hospital for children, but because of increasing numbers, that had to be adapted to deal with what we call our walking ambulatory patients. But it's something, I suppose, in the future that we look at in relation to a new build, if that money ever becomes available for a new build. But individual examples, for instance, I was on last night in the department and there were children coming in who had been referred by the GP service for paediatric assessment. Those children didn't need to stay in our department. Those children were redirected up to the paediatric ambulatory unit, the place where they were going to see and get a period of observation by advanced paediatric nurse practitioners. And we work very closely with them, and we've agreed what can and can't go up to them, and that's audited. And we're developing an interface meeting with the paediatricians to allow more work to occur in relation to that. Mental health, we already have got an interface group up and running, and it deals with the very real problems. I mean, mental health patients are in quite a bit of distress when they generally reach the emergency department, may have drugs or alcohol taken as well. So there can be a combination of factors going on, and we have, over a period of time, provided training to our staff and assessment at the front door of patients with mental health. We have easy access to liaison psychiatry services 24 hours a day, 7 days a week, and they will come over and assess those patients in a timely manner when the patients are suitable to be assessed, because not all patients are suitable to be assessed when they present, as you know. So it all works very well. Are there still problems with it? Yes, of course there's problems with it. I'm not painting a picture that we've got everything sorted and that patients with mental health problems always get a great deal when they come to the emergency department, because they sometimes don't. And there's a variety of reasons for that, and it can be pressures elsewhere on the department. It can be that those resources that should be available for it are doing something else, and it's competing interests. And I suppose the competing interest is one of the major things we have, because suddenly everybody becomes a priority, and it's what's more of a priority than somebody else. And that's a difficulty, and that's a judgment call we sometimes have to make. But yes, anybody who has got mental health issues and is distressed, triage nurses would bring them into a quiet cubicle very quickly from the triage process. and then the assessment of the patient can occur.
Okay, I'm passing now over to Paul for his questions.
Thank you very much for your remarks. Time is very short, but I am going to make a few short comments before asking a couple of questions, but I'm going to truncate the questions. The remarks are briefly these, that of course we're interested in a human rights-based approach to health, and that's an approach that's based on the Human Rights Act, but also international health rights standards that the UK has signed up to, Convention on the Rights of the Child, Disability Rights Convention, International Covenant on Economic, Social, Cultural Rights, all that. And those international conventions have specific helpful provisions on the right to health, and Les has referred to these in his opening remarks. And it's clear that these provisions are very close to the guiding principles that already inform your critically important work, the principles of dignity, respect, privacy, care, compassion, equity. I could go on, but I won't. And I see a human rights-based approach to health as an asset, an ally, a tool to help you, assist you, deliver the guiding principles and your professional objectives. And there's a growing sort of international trend, of which it sounds like you are part. There's a sort of growing international trend to try to figure out how to better operationalize a human rights-based approach, how to make it real in practice in communities, clinics, hospitals, and EDs. And this is, of course, is very much work in progress. It's a new challenge of practical operationalization, which demands a partnership between those who know something about human rights and those who know something about health. And really a partnership between organisations like the North Island Human Rights Commission and organisations such as your own. So forgive me for taking up very valuable time with those comments, but I just wanted to ensure it was well understood that this isn't, that human rights aren't adversarial or oppositional to what you're doing. On the contrary, I have the sense that they can reinforce much of the terrific work that you're already engaged in. I have, I think, 3 questions, but you might not be able to answer all of them. If you can't answer all of them, perhaps you could focus on the third. That, to me, is the most important one. The first question is this: to what degree are human rights explicitly in your trust's plans, strategies and programs? Maybe they're not so much explicit as implicit. And if they're implicit, that's not fatal. But I'm interested to know to what degree they're explicit or perhaps they're implicit. So just brief response to that would be great. Secondly, could you please, I know it's a huge question, but could you help me understand a bit better the commissioning process with your board? And because time is so short, let me narrow the question to this. To what degree are clinicians at the coalface involved? Let's focus on that. To what degree are clinicians at the coalface in some way involved in the commissioning process? That's my second question. Then the third one, which I'm really particularly interested in, is this. You've emphasized that human rights principles are integral to the trust. My question is, this third question, which for me is really important, I haven't got it clear in my mind yet. To what degree is the board responsive to this human rights-based approach?
Thank you, Professor Hunt, and I'll try to be brief in my answers. I think questions 1 and 3 are enjoined. In terms of human rights being explicit within our organisation, they are part of our board guidelines, they are part of our board etiquette, they are part of our engagement and consultation in terms of key changes. When we're doing equality impact assessments, they form part of that. When we develop a new policy or procedure, Linda, who's here from our equality unit today, will support the staff to make sure that human rights are properly considered as part of that procedure. But I have to agree with you, it is about how we make this real to staff. So for me, when we were developing our vision and our values, we went out to staff and we said, what kind of an organisation do you want to work in? And they told us they wanted to work in an organisation that provided good quality care, that respected people's individuality and treated people with dignity, and that's our vision. So it comes from both the top of the organisation and from the front line. So I hope that answers questions 1 and 3. In terms of our commissioning process with the board and clinician involvement, we are stronger when we are engaging with our commissioner, with our clinicians beside us. So Debbie talked about the money, the $750,000 that we've recently got to completely reshape our medical model, the question you asked, Commissioner Reynolds. And when we were in the room having that discussion, Seamus was there, Philip was there as the Associate Medical Director for Medicine. We had Frances Rice as our Director of Nursing in the room. So when we speak with one voice, we have a more compelling case to make. And certainly when we are supported by our local community and by our users, that voice becomes almost, it is irresistible. So it is about that we're all working for the one thing, and if we passionately believe it's the right thing to do, we're in the room to make that argument. And maybe, Seamus, I don't know whether you want to add to that or not.
Excuse me, Seamus, if I may. I just want to... I'm interrupting you, excuse me, but I'm worried about the time, and I just want to make sure I've understood the answer to what... Doesn't matter what the number was, I think it was question 3. But it was the question of, to what degree... Let's say you go to the commissioning board with some great, maybe innovative intervention, which is driven by human rights concerns. So there you've got human rights in all your documents. So you say, look, we really want to do this and we need funding to do it, and it's reflective of a human rights concern. So I'm interested to know to what degree the commissioning board are likely to be responsive to that, or will they say, oh, well, it doesn't really fit in certain indicators we've got or our priorities. And might you hit a brick wall there? So if you come explicitly with a human rights-based approach, in quite a specific practical thing, not just airy-fairy blah blah, it was quite a specific thing which is shaped by human rights, will they be responsive or not?
I suppose because human rights is so embedded in the needs of our population, it's very difficult to sort of see that something that is a very specific human rights issue.
Safely, though, you might say it's absolutely necessary for patient safety.
And but that applies to suppose to everyone. I suppose maybe an example I would give is when we have a large travelling community within the Southern Trust, which I'm sure you're very much aware. Mm-hmm. And because of that, both from a commissioning perspective, but also from the Trust, we work together to get small sums of money that would support that travelling community to access both primary care in terms of being registered with a GP, but also in terms of how they were better informed to access the generality of our services. So I don't think we ever get in conflict because my colleagues in the board are as committed to this good quality care. I mean, we very rarely get in conflict. The difficulty is that when resources are very, very scarce and there's a huge amount of demands on it, how do you make sure that by thinking about human rights, you protect the vulnerable and all of that? So I think focusing on human rights in this very difficult financial climate, I think will guide us to make the right decisions.
And you don't have experience of the commissioning board being sort of resistant to any human rights shaped interventions that you might advocate. You find them, you're on the same page with them in this respect.
Certainly that would be my experience, okay. Professor Hunt.
Okay, yeah. Thank you very much. Excuse me, Seamus.
Okay. I'm conscious of time here, and we have a second person to get through before we take a break. Are there any just final comments you'd like to make? And I say that in the knowledge that if you'd like to, and we've said this to all witnesses, if you want to expand on any of your answers today, or there are areas that you want to draw our attention to, we are more than happy to take a further written submission from the Trust. So that offer remains. But is there anything you'd like to say?
Just in the interest of time, Chair, I'll make my comments very brief. I mean, we have come here today to tell you about what happens in the Southern Trust, but I hope we haven't given the impression that we are that everything's rosy in the garden.
Sure.
We know,
Yeah.
we absolutely accept that there are further improvements that we have to make. And we also accept that there will be learning coming out of this process that we will want to adopt. We also want to learn from what the users are telling the Commission, so we very much look forward to your report. But it is to just reassure you that we are coming here in the interests of being open to improvement, and that we really know that there are things that we could do better, and we're committed to do that.